Hello, I'm Dr. Steve Kopetsky, a preventive cardiologist in Mayo Clinic in Rochester, Minnesota. And this is the next in our series of interviews with the expert for the prevention segment. It's my pleasure today to introduce Dr. Scott Wright, who's a professor of medicine here at Mayo Clinic in the Department of Cardiology. Welcome, Scott.
Thank you very much, Steve. It's a pleasure to join your award-winning podcast and to be able to share with our patients at Mayo Clinic.
Well, thank you. Our subject today is new RNA therapies for treatment of ASCVD, prevention, and dyslipidemia. And Scott, you've been very involved with these studies. So what are the new RNA therapies?
Yeah, thank you, Steve. And this is really an exciting era now because we have therapies which do not have to be given every day to allow you to have control of a variety of your risk factors that are lipids in case you forget to take your statin or other oral medication, as most of us will forget on occasion. There are new therapies which target LDL cholesterol, triglycerides, and lipoprotein A. The one that's FDA approved targeting LDL cholesterol is something called inclisiran, sold under the trade name of Leqvio. And it's a medication that's given typically every 6 months as a small injection, sort of like getting a flu shot every 6 months. And it lowers LDL cholesterol between 45 and 55%, so around 49 to 50% in almost all patients. And it's very durable. And the safety data have been very reassuring. And the most common side effect for this type of medicine, believe it or not, is just some itchiness or redness for a day or two at the injection area intermittently, not even every time you get the injection. So we now have medications that don't cause muscle pains or raise the risk of getting diabetes or having any other symptom or side effect, and that really do help lower cholesterol and keep it low for people, especially if they forget to take their oral medicines along with it.
That's very exciting. So how do these differ from the COVID-19 vaccine?
Yeah, that's a great question, and I think it's an important one that patients really ought to think about. There are really three types of RNA therapies that one can give. The COVID vaccination and other vaccines that use RNA involve RNA that the body takes up, and then it incorporates that into the cellular structure to synthesize proteins. And in the COVID vaccine, it synthesized the spike protein that would be expressed on cells, and then our bodies formed antibodies and T cells against the spike protein. The therapies which lower cholesterol and other lipoproteins are actually RNA therapies that do not cause proteins to be synthesized like the COVID vaccine, but actually block the synthesis of protein. So let me explain it this way. When you take a statin medication, a fibrate or niacin or anything else, you're actually taking a pill that you're absorbing systemically, and it's working throughout your body. It does work in the liver, but it also is absorbed throughout the body, and you can have muscle side effects and other things from these pills. Now, the injectable therapies actually go to the liver, the site of action where a protein called PCSK9 is synthesized. And the PCSK9 protein is probably the biggest regulator of cholesterol levels in the body. So the small interfering RNA therapies are taken into the liver cell, and they actually turn off the translation of PCSK9 messenger RNA to make the protein PCSK9. And so they hang around in something called the RNA silencing complex. And if you've ever watched the video game Pac-Man, they basically work by causing that RNA silencing complex to chew up the RNA that makes PCSK9. So that's how they work. So very different and almost the opposite of what a COVID vaccine will do. And there's the third class that we can get into if you want to of RNA therapies, which work slightly differently in the cell, but they also shut down the translation.
Very good. So you already mentioned that the only one's approved right now is for LDL lowering, and this is approved for LDL above goal. How do you use these therapies? When do you go to them, and how do you manage them?
That's a really good question, and I think it's important that patients understand that these are not first-line therapies. Not everyone will need them. Not everyone should ask for them on their first office visit to see a physician or other provider. They're really used when you take a statin and your LDL cholesterol cannot be taken to a level low enough to prevent the development of heart disease or further development of heart disease, or real commonly if you're having muscle side effects from statins. 20 or 30% of the patients that we give statins to have some degree of muscle side effects. Maybe really severe side effects in 5% or 7%, but many patients have these muscle side effects. And so for many years, we just didn't really have a therapy that we could offer them to treat cholesterol when they have the muscle side effects. So they're used in patients who, for instance, have had a heart attack or have had a stent or bypass surgery or are at high risk and have high cholesterol that's not being adequately controlled by the statin, or they have muscle side effects on the statin, so they need an alternate therapy to the statin. And that's really where these drugs are to be used for the most part.
And are you continuing your current therapy? You know, if it's a ezetimibe, a statin, bempedoic acid, et cetera, or are you using them in place of?
No, we generally recommend if you're taking a statin or a statin plus ezetimibe that you continue those therapies when you start the next step. Because the statins and ezetimibe have both been shown to reduce your risks with a heart attack or developing heart disease or needing revascularization like a stent or bypass surgery. So they're not a substitute. Now, many patients will ask to come off their statin or come off their ezetimibe, and I understand that. But we really don't recommend that. They're used in addition with. Now, of course, if you cannot tolerate a statin or ezetimibe, then you don't have to be on those medicines. But if you are taking them and they are working for you, we recommend your provider keep you on them when you get the injectable.
Good. So if the inclisiran is given on day one, then at 3 months, then every 6 months after that, when do you generally check for LDL levels, lipid levels?
Yeah, great question, and thanks for bringing that up because when you start inclisiran or Leqvio, you do have to get a dose on the first day and then a booster dose at 90 days, and then it's every 6 months thereafter. I recommend checking cholesterol right before the next injection. That way you know how well you're doing, and those levels are going to reflect what your steady state have largely been over the last 3 to 6 months of time.
Good. So, and you said booster dose, but it's all the same dose.
Yes, it's all the same dose. It's 300 milligrams of inclisiran sodium or 284 milligrams of inclisiran alone, and that's the only dose that comes in. It's in a pre-filled syringe. It's just really like giving a vaccine, and the needles are tiny, and patients have never complained that it hurts or stings.
And so it's given, it's in the office or an infusion center.
That's right. It was approved by all the regulators worldwide to be given under supervision of a physician or provider or at their discretion at a center that's authorized to do it, where there are nurses who can give you that injection. So in the U.S., it's a physician's office or an infusion center.
And what do you do with your snowbirds that go to Florida, Texas, California, Arizona?
Well, if they're ready for another injection or due for another injection, we can send a authorization to a center near where they are. They can go get it. Most large cities have several infusion centers. I think I was looking for an infusion center for a patient in Phoenix, and I found 10 or 12 centers that do it. So you can do that. Or if they really can't get it where they are and they're going to be home in another 2 or 3 months, you can just wait to give it until they get back.
Now, in general, do you have to fail a PCS, one of the standard PCSK9, every 2-week therapies? And is there any other group that you may prefer it for because of reimbursement issues?
Yeah, a lot of patients have insurance that don't want to pay for inclisiran before they try something like Repatha or Praluent first because those two drugs are generally less expensive by a small amount than inclisiran, and so many of my patients have to be stepped through one of the other drugs. If you have a tremor or if you just cannot tolerate those, then you typically will get approved without prior authorization. But yeah, some patients require it, some don't. Medicare does not require it, but private insurance may require one to step through one of the other PCSK9 monoclonals.
So the Medicare patient, you can go to this earlier. That's nice to hear.
You sure can.
Now, you've already talked about their effectiveness. Tell us about the side effects.
Yeah, the biggest side effect is injection site reactions, like a small redness, itchiness, scratchy area that typically occurs after a vaccination. It lasts a day or two at most. Almost all the patients we've seen in the reports are mild to moderate. I haven't seen a case of severe. There really aren't other side effects. We've published a large amount of data looking at safety. What I will say is that occasionally somebody might see a small rise in their ALT from, say, 35 to 45, and then that goes back to normal. But tripling of the liver enzymes just doesn't happen with these therapies at any greater rate than placebo, and that's true for the monoclonals as well.
Now, there's some data that just lowering cholesterol significantly can give muscle aches. Have you seen much muscle aches with this?
Surprisingly, no. I'm sure we may see someone who has it or believes it's attributable to it, but in probably 14 or 15,000 patient years of treatment with the data analysis, we just haven't seen muscle aches or pains reflected. That doesn't mean you couldn't have it, and if you start one of these medicines and you feel like you're getting a side effect, talk to your doctor about it.
Yes, I guess it's important to remember that statins have been out for 20 years before we discovered they really increase incidence of diabetes. So we have to keep vigilant, don't we?
We do keep vigilant. We have published now a couple of analyses looking at the risks of developing new diabetes or worsening diabetes, and so far the data are incredibly reassuring that there is no risk there. But that doesn't mean 1 in 10,000 people or 1 in a million will see that. But something more common like with statins, we're not seeing.
Well, Dr. Wright, this has been a great summary, and hearing about inclisiran, these RNA therapies, they are coming. It's good that we all start to learn how to use them, appreciate their benefits and their lack of side effects and off-target effects. This is a great drug we can now use for our armamentarium for treating hyperlipidemia, and I think we both agree that everyone should be able to use these drugs, not just cardiologists, lipidologists, internists, family practitioners, nurse practitioners should all be using this drug.
I would just say to people interested in this class of therapy, stay tuned. Lipoprotein A therapies are likely to be approved in the next year or two, as are other drugs.
Great to hear from you, Dr. Wright. Thank you for joining us.